Hello, this is a video lesson on procedures of the urinary system. Starting off with what type of contrast is what we use in the urinary system is water-soluble iodine. Which type is less likely to cause an adverse reaction? Well, that'd be the non-ionic iodine. Lower concentrations are required for the bladder studies because of the large amount required to fill the bladder. And higher concentrations are used for excretory urography, otherwise called EU. The ACR, which stands for the American College of Radiology, specifies that excretory urography is useful in demonstrating the collecting system and ureters and evaluating ureteral obstruction, compression, and displacement. It is also lower dose than CT. Even though we don't see a lot of these procedures, I just want to let you know that what this stands is from the ACR. For the urinary system, we have two filling techniques. One is called antegrade and one is called retrograde. Antegrade means contrast going in the kidney in the normal direction of blood flow. Antegrade is going as the reverse order. So antegrade is where contrast enters the kidneys, and the one method is by percutaneous antegrade urography, which we do not perform in radiology, specifically in diagnostic radiology, but we do perform EU or IVUs in some centers. And EU stands for excretory urography, IVU stands for intravenous urography, and we're going to talk about that procedure. For the retrograde procedures, we have a retrograde urography exam. That's where contrast is injected directly into the ureters with using ureteral catheterization. We have cystography, in which contrast is injected into the urethra, and that's using urethral catheterization. And then we also have cystourethrography, which is contrast injected into the urethra again, but we're going to look at the bladder and the urethra this time, but it's through urethral catheterization. As far as preparation of the intestinal tract, bowel prep is not attempted in infants and children. A carbonated beverage may be used to distend the stomach with gas, though, and you can see where the stomach has been distended with gas in this particular image, and therefore the renal calyces are visualized. On the other hand, we could also turn the patient from AP, where there's lots of gas that's over top of that kidney, to a PA projection, and that just all that did was just move the gas over just a little bit and allowed us to see the kidney. So that's a possibility as well. For the IVU patient, the patient should be well hydrated. We want to have hydration, particularly is important for patients with diabetes, with multiple myeloma, high uric acid levels, and these conditions put patients at risk of increased risk for contrast medium-induced renal failure if they're dehydrated. For the patients for retrograde urography, they should drink 4 to 5 cups of water for several hours before the exam. There's no preparation usually required for the lower urinary tract. For the excretory urography procedure, the intestinal tract must be kept free of gas and fecal material. Prep can vary, but a common method for the IVU is a low residue diet 1 to 2 days before the study. A light evening meal on the day before the exam. It could be a non-gas forming laxative when indicated the day before the exam, or even NPO after midnight the day of the study. For equipment, we're going to have standard radiographic equipment sufficient for excretory urography and most retrograde studies of the bladder and the urethra. We could have a combined cystographic radiographic unit needed for retrograde urographic procedures that require cystography. Timed interval and body position markers should be used for the IVU. We should have a crash cart available and make sure it's stocked and know the location, and then also be aware of our venipuncture supplies. So let's begin with the IVU. This includes an AP projection, of which could be a scout and also the series, the RPO and LPO, and then finally ends with a postvoid. This procedure is also called an EU, excretory urography. It shows the structure and function of the urinary system. Indications for an IVU include evaluation of known or suspected ureteral obstruction, recurrent urolithiasis, assessment of suspected congenital abnormalities, evaluation of upper urinary tract to investigate abnormalities that increase infection risk, assessment of upper urinary tract lesions that may explain hematuria, and assessment of the effects of the traumatic and therapeutic interventions. Contraindications relate to the ability of the kidneys to filter contrast media from the blood and patient's allergic history. Some contraindications may be overcome by use of non-ionic contrast agents. High-risk patients may be evaluated with other modalities. Risk factors include asthma, a previous contrast reaction, circulatory or cardiovascular disease, elevated creatinine level, sickle cell disease, diabetes mellitus, or multiple myeloma. Before the procedure, the patient must empty the bladder and change into a gown. We're going to review the blood chemistry. Normal creatinine would be between 0.5 and 1.2. Normal GFR is between 90 to 120. And then the department's protocol would ascertain whether the patient can have the procedure, continue with the procedure. We would perform a scalp radiograph, usually perform venipuncture, and administer 30 to 100 milliliters of contrast for an adult patient of average size. This procedure requires the markers that we mentioned earlier, so it's going to be timed radiographs that varies according to the department protocol. The most common radiographs for the IVU exams are the AP projections at time intervals ranging from 3 to 20 minutes. The greatest concentration of contrast media normally occurs in 15 to 20 minutes after injection. The AP oblique projections are often taken at 5 to 10-minute intervals, and unless bladder or voiding urethograms are to be made, the patient is sent to void. Post-void radiographs of the bladder may be taken if they're used to check for small tumor masses or enlarged prostate for males. After the procedure, the patient is instructed to drink extra fluids to aid in flushing the contrast. For the AP projection, our patient is going to be supine and with the support under the knees. We're going to center the mid-sagittal plane to the midline of the image receptor. Our arms will be out of the collimated field, and we're to center at the image receptor at the level of the iliac crest. If the patient is too tall, we can take a second exposure of the bladder with just the bladder with a central ray directed 2 to 3 inches above the upper border of the pubic symphysis. That would require, in that case, both a 14 by 17 and a 10 by 12 crosswise. Afterwards, we'll suspend an expiration just like we would do any abdomen images, and after we inject the contrast, we'll see the kidneys, ureters, and bladder filled with the contrast media. Prior to injection, we're going to see an image like we will on the next slide. So this would be a typical scalp image. So images that we can see are the kidneys, the lower border of the liver, the lateral margin of the psoas muscles. Other items are extrarenal lesions that may result in the IVU being canceled. Contour of the kidney, their location in the supine position, the presence of renal calculi or calcifications such as phlebolymph. It verifies bowel preparation. It permits alterations to exposure factors for future projections, and an upright AP projection can show the mobility of the kidneys. An AP oblique or lateral projection or both may be required to localize a tumor or differentiate renal stones from gallstones or calcified mesenteric nodes. We're going to have timed images after contrast media injection. And so these images were taken at 3, 6, and 9 minutes and are marked accordingly. So the evaluation criteria, whether we have AP or PA projections, is we get the entire renal outlines, we get the bladder and the pubic symphysis, and a separate image is needed if the bladder is not included. No motion. Contrast media must be in the renal area, the ureters and the bladder. We want to see the surrounding anatomy. If there's compression devices, if they're used, should be shown. vertebral column should be centered. There should be no artifacts from the elastic in the patient's underwear. The prostatic region inferior to pubic symphysis in older males should be shown. We should always show the time marker, and the PA projection should show the lower kidneys and the entire ureters, and we would see the superimposing intestinal gas and the AP moved then for the PA projection. Oblique projections, we're going to do either LPO or RPOs, and they're going to be 30-degree obliques. The midcoronal plane in this case does form a 30-degree from the image receptor. We're going to center at the level of the iliac crest. We're going to be perpendicular, entering about 2 inches lateral to the midline on the elevated side. Our collimation is going to be about 14 by 17 for smaller patients. We can collimate in on the sides, 1 inch, and we'll suspend at the end of expiration. We're going to show an AP oblique projection of the urinary system, the kidneys, ureters, and bladder filled with contrast, the elevated side of the kidneys parallel with the image receptor, and the downside kidney is perpendicular to the image receptor. So we're going to see the patient rotated approximately 30 degrees. We're going to see the no superimposition of the kidney remote from the image receptor on the vertebra, the entire downside kidney, which is, as said, shown on here as well. We're going to see that we've got the bladder and the lower ureters on the 14 by 17, contrast in both the kidneys, ureters, and the bladder, and the surrounding anatomy. And the time marker finally is shown. We can also do AP pre and post void projections for an IVU. The patient will still be supine. The arms will be by the side or on the chest. The legs will be extended with slight flexion. We're to center 2 to 3 inches above the upper border of the pubic symphysis, and our central ray is going to be perpendicular. Our collimation is going to be a 10 by 12 crosswise, and we're going to suspend an expiration. We'll see the bladder filled with contrast media and the pre, and then there'll be less than the post. So here's the pre and the post shown in this image, this slide here, showing the bladder, no rotation of the pelvis, the prostate area in the male, and the post-void images clearly labeled and showing only residual contrast medium. Retrograde urography. We only have 3 images with retrograde urography, which include the AP scalp, AP pilogram, and an AP ureterogram. For the retrograde urography, it requires catheterization with the ureters with the ureterocystoscope. The contrast is injected directly into the pericalyceal system. It provides improved opacification of the renal collecting system with little physiologic information provided. It's indicated for evaluation of the collecting system in patients with renal insufficiency or contrast sensitivity. This is classified as an operative procedure. We could have an actual cysto room in which the patient's in the top picture, or we can use a C-arm for imaging instead. It's carried out under aseptic technique by urologist. The patient is in a modified lithotomy position, and for the images, we're going to have the central ray perpendicular and directed to L3. So for the AP scalp, if we had the regular imaging room, not using the C-arm, we would have a more 14 by 17 inch image of the patient, and then the AP pilogram would be the same. And here's the AP ureterogram. For the lower urinary tract, we have 2 procedures. There's a cystography procedure and there's a cystourethropy procedure. For both procedures, they're indicated for vesicoureteral reflux, for recurrent lower urinary tract infections, bladder trauma, lower urinary tract fistula, urethral stricture, and posterior urethral valves. Contraindications are related to catheterization of the urethra. The contrast media used is a non-iodine with decreased concentration, only needed 30%. For both of these procedures, they're going to void beforehand. For catheterization, the nurse will catheterize the patient if there already isn't a catheter in place, and so therefore a sterile catheterization tray would be required. A Foley catheter would be used on infants and children. For the contrast injection, it's going to be introduced into the bladder by injection or by infusion through the urethral catheter within the urethral canal. After injection, the catheter is clamped and taped to the thigh, and the voiding study is used to detect ureteral reflux. So let's begin with cystography, in which there's an AP, RPO, and LPO, lateral and apiaxial projections that can be performed. For the AP projection cystography, the patient's going to be supine. We're going to center the mid-sagittal plane of the body to the midline of the image receptor. We're going to center 2 inches above the upper border of the pubic symphysis or at the pubic symphysis for voiding studies. We're going to center the perpendicular to the center of the image receptor. We're going to collimate to a 10 by 12 lengthwise, and we're going to have the patient suspend at the end of expiration. The bladder is filled with contrast medium. If reflux is present, the distal ureters would also be visualized. So in this image, we're going to be looking at to see whether the regions of the distal end of the ureters, the bladder, and the proximal portion of the urethra. There should be contrast medium in the bladder, the distal ureters, and the proximal urethra, and we should be looking at surrounding anatomy. For the apiaxial projection for cystography, the patient is still supine. We're going to center the mid-sagittal plane of the body to the midline of the image receptor. We're going to center 2 inches above the upper border of the pubic symphysis or at the pubic symphysis for the voiding studies. We're going to direct the central ray 10 to 15 degrees caudad to the center of the image receptor. A 5-degree angulation is used when the bladder, neck, and proximal urethra are the main areas of interest, but it enters 2 inches above the upper border of the pubic symphysis. Collimation is 10 by 12 lengthwise, and we're going to suspend at the end of expiration. Our image is going to be an apiaxial filled with contrast media. If reflux is present, the distal ureters will also be visualized as they were in the previous image too. And so we're going to see the regions of the distal ends of the ureters, the bladder, and the proximal portion of the urethra, the pubic bones projected below the bladder neck and the proximal urethra. The contrast medium should be in the bladder, the distal ureters, and the proximal urethra, and we should see surrounding anatomy. For the AP oblique projections, we're looking at RPO and LPOs could be performed, one or both, depending upon physician preference. These are 40 to 60 degree obliques, depending again upon preference of the physician. We're going to center 2 inches above the upper border of the pubic symphysis and approximately 2 inches medial to the upper acis at the pubic symphysis for the voiding studies. We're going to be perpendicular to the center of the image receptor, and we're going to collimation that's going to be 10 by 12 lengthwise like it has been for the last couple of procedures, and we'll suspend at the end of expiration too. The obliques are going to be giving us projections of the bladder filled with the contrast medium. If reflux is present, the distal ureters are also visualized. And so with this, we're going to look at the bladder and the distal ureters and the proximal urethra in the oblique position. And if we're looking at the voiding studies, we'll see the entire urethra visible and filled with contrast media. We're going to have the urethra overlapping the thigh on the oblique projections for improved visibility. The lateral projection for cystography is where the patient is in a lateral recumbent, either the right or the left. The midcoronal plane is centered to the midline of the image receptor, and we're going to center 2 inches above the upper border of the pubic symphysis at the midcoronal plane. Or we're going to be perpendicular to the image receptor again, and our collimation is 10 by 12 lengthwise, still suspending at the end of expiration. Our images are going to show lateral with showing both the anterior and posterior bladder walls and the base of the bladder. If reflux is present, the distal ureters will also be visualized. And so looking at this, we're just again seeing the bladder just shown in the lateral projection this time, and the contrast medium being visualized in it, and the bladder distal ureters visible through the pelvis. Cystourethropy can be performed on both males and females, and so many times this is preceded by an endoscopic exam, after which the bladder is catheterized, so it can just be drained before the contrast is injected. We're only going to have two projections. For the female, we perform the projections AP, and for the male, they're going to be in an RPO. So for the male, we're going to perform an RPO position. The patient is supine, and we're going to have them adjust into an oblique position so the bladder, neck, and entire urethra are delineated as free as mobility and superimposition. We're going to rotate the body 35 to 40 degrees and adjust it so that the elevated pubis is centered to the midline of the image receptor. The physician inserts the contrast medium loaded urethral syringe into the urethral canal. You're going to ensure filling of the entire urethra. Where central ray is going to be perpendicular to the image receptor, and we're going to be enter at the level of the superior border of the pubic symphysis. Collimation is 10 by 12 lengthwise, and we're going to suspend at the end of expiration. The bladder and the urethra are filled with contrast during the voiding study. And so here's an image showing the voiding cystourethrogram for the male patient in the RPO position, so there's no superimposition of anatomy on the urethra. For the cystourethrogram in the female, we're going to perform an AP projection only. The patient is supine, the cystoscope is removed, and the catheter is inserted into the bladder so the bladder can be drained just before injection of the contrast solution. We're going to center the image receptor at the level of the superior border of the pubic symphysis, and then our central ray will be directed perpendicular to the image receptor. We're to suspend respiration at the end of expiration. Collimation will be at 10 by 12 lengthwise, and we're going to see the bladder and urethra filled with contrast during the voiding study. And this is an image showing an AP projection of this female patient. And this concludes our lesson on the procedures of the urinary system.